I think my biggest concern is that I don't believe we spend enough time developing leaders in pediatric nursing. I think, I think it's well known that nurses choose certain specialties because of their personality or the kinds of things they like to do. And a lot of nurses who are pediatric nurses are incredibly caring and compassionate. They love working with families, but they're not necessarily the same kind of individuals who are really going to put themselves out there and really take charge and move some issues forward. And I do worry a little bit about that. I don't think we have spent enough time developing those leadership competencies so that they can be assertive, fight for children, fight for children's rights in healthcare, things like that, and frankly negotiate through these incredibly complex systems that they have to work in.
Well, I think we really need to look at why we have pediatric nursing, and that's really to care for children's health and also for their families. And my greatest concern is when we look at the child health indicators, children are doing worse today than they have in many of the past decades. If we go back to the mid-1850s, to the origin of pediatric nursing developed in needs to societal conditions and societal demands. My concern for pediatric nursing today is that if we can't really enrich pediatric nursing and have the very best quality curricula and clinical opportunities and the best and the brightest going into pediatric nursing, it's going to have a real impact on the health of children and families in decades to come.
I think when you ask me that question, I immediately think about the changing demographics of our population, the growing numbers of children, the increase in obesity, the increase in chronic diseases among that population. And so I'm not as concerned about pediatric nursing, but I'm concerned about preparing nurses to deal with those changing demographics and to be prepared to address those and where they can make the biggest impact.
I think they're in a phenomenal position to do that. This alliance of organizations that's been set up, especially because it crosses education and practice, can be incredibly powerful by bringing nurse educators, both in the practice settings as well as the academic settings, together to chart a joint future. There's no question, I'm a dean and of a very large school in the Midwest, and I don't think there's any of us who don't think that the only way to do this in the future is to partner across both settings. Whether you have an academic, are in an academic medical center such as my school or not, we still need to partner with our colleagues in practice to be able to know what kinds of experiences we need to just enrich the experiences of our students and to prepare them the best we can for what they're going to face when they graduate.
Well, again, if I talk historically, one of the things that has happened is pediatric nursing has always been splintered for a variety of reasons. This is one of the first times all the players have been together at the same table. So there really is strength in numbers, and there's also strength in creativity. So what we really need to do is create a very solid infrastructure amongst ourselves, but also in collaboration with our partners both in healthcare, other aspects of healthcare, healthcare education, as well as with community groups and other interested groups that can advocate for us. That said, some of the things that I think we need to do right from the beginning is have not only standards that everyone can use for a platform, but also give them ready-made resources that they can begin moving right into their curricula and use and then adapt for their immediate setting that come at a very high level of evidence and applicability.
I have many ideas about that and in response to that, but I think the most concise response is looking at opportunities for where you can integrate and provide resources for faculty. I think faculty development is a huge issue and a need, if you look at the data that comes out. You look at providing resources so that faculty can easily integrate care of children and families within the curriculum, being innovative and designing curriculum that are not the way we always used to do it. I think we need to look at new clinical sites, we need to look at new ways of packaging content, providing exemplars, so that when you're teaching an exemplar on environmental health or an exemplar on genetics, that you have resources and case studies that faculty can use to integrate that content and get those principles across.
Only positive. I don't see any at all downside to that. Again, it's that practice academe partnership. I think as an academic, I will say that I would, and as a dean, I would clearly put resources, not just for the student's sake, but for my faculty's sake. Again, when you have to work across systems, you develop some leadership competencies that the faculty will. They'll also be in more of a leadership position than if they were just taking their groups of students onto different units, because they'd have to craft the curriculum with their practice partners. And I just see it as a win-win for everyone. And I think it does lessen some of the pressure. You know, if only 11%, or 10 to 11% of students actually go into pediatric practice, why are we going to teach every student as if they are? And the residency, and perhaps backing the residency up into a practicum experience, most of us have those capstone practicum experiences in the baccalaureate education, we can really ensure that those who know they're going to go actually do participate, but get the depth that they'll then need. But not every student needs that depth.
I think pediatric nurse residencies are one of many ideal paths that we should go down. As a caveat, most of the nurse residency programs are linked now to acute care settings. If we take a look at, particularly under the new Patient Care Acts, and where we'll be looking more and more at integrated healthcare systems, both vertically and horizontally integrated, and children's hospitals will move in that direction, I would very much like to see nurse residency programs really be based across the continuum of care, including those parts of children's hospital networks that are community-based. So when that individual goes through a nurse residency program, they're flexible enough to move and to understand the demands of children, not only in acute care settings, but also their chronic care needs in the community, and most importantly, health promotion.
Well, I think we in nursing, not just for pediatric nursing residencies, but I think we are moving towards identifying the need that individuals who come out of our entry-level programs are not prepared necessarily to immediately jump into our complex healthcare institutions. And that's not to say that they're not being well prepared, but it's also reflecting on the changing complexity of our healthcare environments. Also the specificity when somebody goes to work at a particular institution because of the changing technology and the systems and the policies. So I think we're moving towards creating residencies for all baccalaureate graduates for nurses, so that they can, we've found fantastic results in the UHC AACN post-baccalaureate residency program in retention, satisfaction, and feedback from employers on their ability to really impact practice. So I think there are many opportunities to look at creating and designing residency programs that are specifically geared with a focus on care of children, but to build it on a foundation that's already there for other post-baccalaureate residency programs.